dive, hold on to those values as we dive into some of the data and some of the values of harm reduction. All right, next screen.
Is that screen working for you, Lydia?
Yeah, except I can no longer see it.
Okay.
Because it's blocked by a pop-up. All right, sorry about that. This is the problem with doing Zoom via an iPhone. All right, so we're going to be talking about substance use disorders and addiction today. And what I always like to do when I'm talking about substance use disorders and addiction is I like to just create some baseline understanding of shared language that we're going to use. Sometimes I use language that people aren't familiar with, and I want to tell you a little bit about why and how I come to making those decisions about language. You've probably all thought about the way in which language impacts stigma and the way in which language impacts how we think about things. And it turns out that there's actually some really high quality evidence that highlights how we should best talk about addiction and substance use disorders. And when I say it's high quality evidence, what I mean is this isn't someone saying like, this is the word I think we should use, or I don't think we should use this word. It's not just an academic that published a paper saying this word is good and this word is bad. It actually is qualitative evidence where the same story is told over and over and over again, hundreds of times to hundreds of different people. And then the only thing changed in the story is the words used. So the story is the same, but instead of saying person with a substance use disorder one time, they might say addict another time. Or instead of saying relapse one time, they might say recurrence of use another time. And drawn out of that, of those stories over and over again told, then they asked people if they thought the person in the story was good and moral and had the ability to recover. And it turned out that word choice was really, really important in whether people thought the person that was in the story had the ability to experience recovery and had morals or not, essentially. And so when I say it's high quality evidence, I mean that it's really clear. And again, not just opinion, that words really matter in how we think about people with substance use disorders. And I'll highlight in a second why this is so important, but I want to just go through really quickly and highlight some of the things that the evidence says are useful and some of the things that the evidence says is actually more stigmatizing. And some of these you probably know, and some of them might be a little bit weird. So the first one's addict and alcoholic. They're at the top of this list here. And what I want you to just notice is that both of those, it says stop across the board, except for in mutual aid meetings. So what that means is that the evidence showed that the words like addict and alcoholic that weren't person first. So for example, saying something like person with a substance use disorder or person with an alcohol use disorder, that those were really stigmatizing, that when we use those words and stories, people were seen as being less likely to recover and being more sort of bad. And I don't want you guys to hear me saying that we should be policing people's language. So you'll notice that there's a little note that says mutual aid meetings. So essentially what this is saying is if someone self-identifies as I'm an addict or I'm an alcoholic, or if you go to a 12-step meeting and people introduce themselves as addicts and alcoholics, we're not going to like interrupt them and be like, well, technically that's not the right word. People get to tell their own stories using whatever language they want. But you'll see if we scroll over sort of to medical settings that then it says stop. What this is saying is, hey, we actually know that especially in a medical setting, these words increase stigma and make us think differently about people with substance use disorders. And again, we'll come back to why stigma is so dang important. But the point here is not to be policing people's language and how they tell stories about themselves. But the point is really to say, okay, we want to have as much sort of clinical acumen as possible. And these words increase stigma and they don't convey things in a way that is useful in the medical setting. Same goes for substance abuser or substance abuse. Although that one you'll see, even in mutual aid meetings, we want to discourage it. And this one makes a lot of sense to me because who's an abuser? just think for a second, when we're talking about people that are abusers, who are we talking about? Usually we're talking about people that enact violence. So when I think of an abuser, I think of like spousal abuse, animal abuse, child abuse. And it's not that people that use substances are never violent. Certainly, you can have substance use and violence, and those two things can be connected. But we don't want to stigmatize all substance use by talking about substance abusers and substance abuse. So again, we want to try to avoid that one. And it's not about language policing. I never go around telling people what words they can say and what words they can't say. What I do is I try to use this as a way to acknowledge the language that I use and think really, really mindfully about how I'm talking about people with substance use disorders, especially as someone in long-term recovery. The other one you'll notice here that is really interesting is that we should stop saying relapse in a medical setting. And the preference, I wish that this was somehow communicated on the slide, but the preference instead is to say something like recurrence of use or return to use. And man, that one's really hard. It took me years to get relapse out of my brain because it's so part of sort of a vernacular. But again, evidence is pretty clear that saying return to use or recurrence of use decreases stigma. And then the final one that I'll highlight here is medication assisted treatment. This one's always really surprising to people because we've got the acronym MAT all over the place, right? Probably many of you work in agencies where you've got a MAT team or a MAT clinician. And so here's the good news. The American Society of Addiction Medicine came out and said, okay, we recognize the evidence that says that we shouldn't say medication assisted treatment, but MAT, that acronym, it's everywhere. And because of that, we're going to keep the acronym MAT and we're going to say medications for addiction treatment. So don't worry, you don't have to like change your MAT team name. It's still MAT. It's just that it doesn't mean medication assisted treatment. It means medications for addiction treatment. And the reason behind this is pretty fascinating, actually. What the researchers sort of came to, or what they decided, was that medication assisted treatment, what that often made it sound like, and why it was such a stigmatizing term, was that medication assisted treatment makes it sound like there's real work to do for recovery, and medications are adjunctive, like they're not part of the real recovery work. And I thought that that was fascinating. So the idea it's just medications for addiction treatment, just like we've got antidepressants, just like we've got medications that stabilize blood sugar, we've just got medications that help in addiction. It's not that they're assisting real treatment, they're just part and parcel of the treatment. So again, I highlight this because I think language is so important, and because you might hear me say weird things like return to use, and you might think, why are you saying that instead of relapse or medication for addiction treatment? So I want to give you a little bit of insight into that. And Angela, we can go to the next slide. And part of the reason that I spend so much time on language is that there's some pretty great research that is pretty clear that stigma is the strongest predictor of substance dependence. And it's old research, so it's dependence versus a use disorder. So in the DSM, we switched to use disorders instead of dependence and abuse. But the research, if you kind of dig under what the words are, what it's saying is stigma is the #1 predictor of whether people engage in recovery services, which I think is fascinating. So what this is saying is that when people experience judgment, bias, stigma from healthcare providers, from social workers, from case managers, that's the thing that prohibits them more than anything else from getting into recovery services. That means that if we want people to engage in recovery services, whatever those recovery services might look like, whether it be harm reduction or housing that doesn't include any substances or stopping substance use entirely, that means if we want that for our clients, the #1 thing that we can do is stop stigma within ourselves and really tend to how we pay attention to clients. So that's why I highlight the language piece. If language like relapse or addict or alcoholic or dirty and clean, if that increases stigma, that's one of the most important things we need to get rid of, is the language that sort of bolsters stigma, because stigma is the number one thing that prohibits people from getting engaged in a variety of different types of recovery services, which is pretty fascinating. I think we often think that there's all these barriers to people getting into recovery services. You know, people need to take a bus, or there's no beds available, or people aren't ready to stop using substances. And what the evidence says is that the number one thing is it's the experience of stigma from care providers. And that's us, right? People on this call, we're the care providers. And so we have to then tend to how we treat people who come into our services. And that's one of the things I love about harm reduction. Is harm reduction is all about sort of decreasing stigma and encouraging people to get into services regardless of their stage of change. So we'll come back to that, but that's why I spend so much time talking about language here, because it's so dang important if we want people to get engaged in recovery services regardless of their age, right? All right, next slide. Let's pivot to talking specifically about harm reduction. My favorite part of the next hour and a half is talking specifically about harm reduction. And I just want to highlight that I'm so grateful to be here. On the back end of like all these tech issues, and I didn't figure out how to blur on my Zoom camera so you can see the office I'm in, and like I can't see on the back end of all of that like stuff. I'm just so happy to be here. I think about, you know, sort of the substance use disorder landscape 10 years ago, and I just don't think that we were having the same conversation as openly and including things like harm reduction. We're really in this like pretty amazing and pretty pivotal cultural moment when it comes to how we think about substance use disorders. And I think that's reflected in sort of microcosms like this one, saying, okay, we're going to talk about harm reduction for 2 hours, and specifically how harm reduction relates to older adults. That's amazing. That's not something that I think we would have seen again 10 years ago. And then that goes all the way up to the macro, where Biden is the first president to ever talk about harm reduction. And it's kind of a big deal. And partially it's a big deal because harm reduction is one of the most evidence-based interventions for substance use disorders. If you want to know what works for substance use disorders, harm reduction almost always works. Harm reduction services, for example, like syringe exchange, they decrease communicable illnesses in the community. If you want to think about overdose prevention, getting Narcan into the community always decreases overdoses. So harm reduction just works. When you do a harm reduction intervention, it works. And yet, because of sort of cultural stories we have, and because of stigma that we have, it hasn't always, you know, harm reduction hasn't always been part of the national conversation. And suddenly it is. And I think it's a really exciting moment in time. And I'm just so glad to be here with you all, sort of digging into that and talking a little bit about what that means, especially for people, for older folks that have substance use disorders or that are using substances in a risky way. All right, next slide. All right, so some of you might be thinking, okay, I've sort of heard about harm reduction, but what actually is harm reduction? And harm reduction, I think of it as sort of having two parts. First of all, it refers to policies, programs, and practices that minimize negative outcomes associated with drug use, as well as drug policies and drug laws. But today, specifically, we're going to be talking about drug use. So what are those negative consequences associated with drug use? And I want to highlight here that when we talk about drug use, in this instance, we're talking both about just risky substance use, which lots of people engage with, and then also substance use disorders, which is you know, a medical diagnosis where drug use is really impacting someone's life. Whereas some people just use drugs and it doesn't always impact their lives. But the second element of harm reduction is that it's grounded in justice and human rights. So it's not just about pragmatics of decreasing harm. It's also including people with lived experience in the conversation. It's ensuring that change happens without coercion. And it also is ensuring that people don't have to stop using drugs as a precondition of support. So there are many people that use substances and for whatever reason aren't going to stop using substances. And historically, we haven't always treated them. We've said, well, you're using substances, so there's really nothing we can do for you. And harm reduction says, hey, you deserve our support, even if you're using substances. You deserve to be engaged in services. You deserve, the things that I have available to you, even if you're using substances, because harm reduction, again, it's grounded in justice and human rights. So regardless of the stage of change that someone is, or in the stage of the disease that someone's in, harm reduction says we're going to support you. And that doesn't mean that we never, ask people to leave programs because of behaviors, but it does mean that we don't think like, oh, substance use, that disqualifies you sort of right off the bat, which at least historically in substance use disorders or in behavioral health treatment, oftentimes we ask people to stop using substances before we'd serve them. So we'd often ask people to stop using the very thing that they had learned as a skill to manage their suffering before we offered them other options for decreasing suffering. So this is a pretty big shift. All right, next slide.
Lydia, before we move on, Cynthia Burton has a question.
Yeah.
Cynthia, would you like to unmute?
Yes. When you're talking about harm reduction with clients, well, for me, because I'm a peer specialist, and it's, for me, for being in recovery, it's really difficult at times, because when you get clientele that comes in there and they're talking about trying to stop their opiate addiction, but at the same time they talk about still continue to smoke weed, and they tell me, well, it helps me to stop using opiates or shooting dope. How do you go about trying, and I guess you consider that as harm reduction. But how do you kind of go about it, as well as, if the client is trying to also stop using one drug, but they're still picking up another, is what I'm saying.
Yeah, I love that question. And I think we'll sort of come back to that question a little bit later. But I want to try to answer it at least briefly now, and then we'll sort of loop back around to it. The way that I think about harm reduction is it's sort of both and. So I'm going to meet people where they are today. If what they want to address is opioids and they don't want to address cannabis use, then let's talk about opioids today. That's what we're going to do. And then over time, we might talk about cannabis use. If it's causing suffering in their life, it's going to come up in our conversations. And so I tend to just, wherever someone is today, let's address that thing today. And then we'll talk about the other things over time. And I think a lot about motivational interviewing in this, when I'm answering this question, which is motivational interviewing would say that if you want to talk about something and the patient doesn't, like if you really want to talk about, like, you have to stop using this substance now, and the patient doesn't, then you've missed the mark in creating alignment with the patient or with the client or with the peer. And that sometimes is a little bit more idealistic than realistic, right? Like if I have a patient who's just using a lot of methamphetamines and is really psychotic and wants to not be psychotic, we're going to end up talking about the methamphetamines even if the client doesn't want to, because I'm going to start to like plug it in a little bit because I know that that's the cause of it. But as a general rule, I would say that the thing we're going to talk about is the thing the client wants to talk about, which is tricky.
Yeah. Yep. I mean, they do want to stop using the opiate, but then they're still using the meth. But then also too, then they continue to kind of still use the meth too. So it's like a scale trying to balance itself out. Nothing's balanced itself out. So it's hard to kind of not deal with it, but it's kind of hard to kind of get them where they need to be at sometimes, So
yeah, absolutely. It can be tricky. And I think it's especially tricky for those of us that came up in the 12-step world. And I'm not necessarily saying this is true for you, but certainly true for me. For those of us that came up in the 12-step world, there's this really clear idea of like, you stop using all substances and that's what recovery is. And it's really hard to reckon that with like, oh, that oh, maybe that's not actually best practices. It's kind of a fascinating conversation.
Yeah, I did too. I thought that when you want to stop, you have to stop everything, not just
Right.
one thing and still pick up another and then consider yourself clean. It doesn't work like that in my mind.
Right.
But
Right.
okay.
Yep.
Yeah, but
Gets
thank
tricky.
you. Yeah, it is.
Yeah,
But thank
absolutely. Yeah. Yeah. And we'll come back to it.
Thank
All
you.
right. Yeah, definitely. This is the meat and potatoes of our talk today is tenets of harm reduction. So we're going to hang out on this slide for quite a while and talk through these sort of 6 major tenets of harm reduction. And some of these sound really simple, but then kind of aren't that simple if you start thinking about the way that sort of culturally we deal with some of these things. So the first one is one that seems really simple, but is actually a little bit complicated at times. Illicit drug use will happen. Tenet of harm reduction number 1. Illicit drug use is going to happen. And this one, it seems so like, no, duh. Yeah, okay. Gonna, illicit drug use is going to happen. Yes, of course. And yet, if we really lean into recognizing that that is true, it changes the way we think about things. So, for example, I think about working with my clients that are using methamphetamines. And what I want to ask them to do is just stop using substances. And I hope that they can stop using substances after 1 or 2 conversations about it. But the reality is that that's likely not going to happen. It may not be what they want. It may not be possible based on their housing circumstances. It may not be possible based on, and when I say housing circumstances, I mean that I have a lot of folks who use methamphetamines so that they can stay up all night and they're safe if they're houseless. For whatever reason, many people are not going to stop using substances, and that substance use is going to happen. And if I just acknowledge that the substance use is going to happen, it changes everything in terms of how I think about what my work is. If I think that my work is just getting people not to use substances, I'm going to be woefully unprepared for the number of people that don't just stop using substances. If I think my work is to, send someone to the emergency department and then write an aftercare summary that says stop using opioids and all your problems will go away, I'm going to be really, really disappointed when people continue to use substances. So when I just acknowledge that illicit drug use is going to happen and that drug use is going to happen, then the conversation can shift. And I can start thinking about what are the sort of best outcomes I hope for this person, even if they're going to continue to use substances. I can think about how I can improve their quality of life, even if they're going to continue to use substances. And we can have real, honest conversations that talk about the risks and the benefits of using substances, but only if I acknowledge that illicit drug use is going to happen. I have to first accept that people are going to use illicit substances and that they're not immediately going to stop using substances. Or I can't even begin to have these conversations that are really grounded in justice and compassion and non-stigmatizing content. I got to just say, sometimes people are going to use substances. And then I want to talk about not the substance use itself, but I want to talk about the harms associated with the substance use. So I think a lot of times in healthcare, especially, we get really attached to stop using the substance. And we sometimes don't think about what are the actual harms associated with the substance and can we address that instead? Can you guys think of some examples where sometimes we get sort of tripped up and we want to focus on stopping the substance use, but what might actually be more useful is to think about the harms associated with the substance use. And I would love it if someone could put this in the chat and then someone could read it out loud.
I'm happy to help with the chat.
Thanks.
Okay, folks, don't be shy. Heart disease from Kai Nichols. Thanks, Kai, for kicking us off.
Yeah, and Kai, can you say more about what you mean by that? I can infer what I think, but I don't want to make assumptions. When you say thinking about heart disease, tell us a little bit more.
Sure. Long-term risks of most substances, affects the heart. So as we are talking about older adults, perhaps that is one way that we can start conversations with folks as they start to have concerns about, cardiovascular health. I'm an older adult specialist, so this is one of the ways that I think about starting conversations is with regard to cardiovascular health and how their substance abuse may be contributing to that. And maybe we don't talk about that, but maybe open-ended conversations that start thinking with regard to that.
Yeah, I love it. Yeah, absolutely. So shifting the conversation to cardiovascular health, which could bring up topics of alcohol use, of injection drug use, of methamphetamine and other stimulant use. And the focus is on limiting risks associated with heart disease, not necessarily stopping all substance use.
Mm-hmm.
Yeah, I love it.
Lydia, do we have time to hang out on this piece, the interaction piece? We've got some real heartfelt responses coming up. I want to acknowledge Jacqueline, or sorry, I may not have said that correctly, but thank you. We will definitely spend some time on her response. We have a response that says, I encounter people who like to take drugs, but they end up in hospital detained because of psychosis.
Yeah, absolutely. And can we go back to, you said you really wanted to spend some time on Jacqueline's. Was that Jacqueline's?
No, Jacqueline says, right now I am personally struggling with alcohol. I'm very fixated on recovery. However, I haven't thought about how bad it is for my liver, etc. So kudos for being so authentic and sharing her personal struggle. I'm sorry, I don't want to assume gender, her, Jacqueline.
Yeah, thanks so much for being vulnerable. And I would love to talk about that, and let's come back to it. Absolutely. Yeah, okay. Definitely.
So we have saving money spent on drugs and alcohol, etc., may help to improve quality of life and enable them to achieve other goals.
Yep, absolutely. And I love that one because it really pivots the conversation to say, hey, let's think about how we can save money versus let's think about how you can stop using opioids. Really pivots the conversation. And just for a moment, think about the experience of the client. They're acknowledging that you recognize what they are most interested in versus what they may experience as stigma if you're talking about substance use. If you immediately go, well, if you stop using substances, then you're going to save more money, that can be experienced as deeply stigmatizing. But if you say, hey, I hear what you say is that you want to save more money, let's talk about how you can do that, you may end up having a very, very similar conversation, but the frame of it gets shifted in a way that's really positive for the client. So I love that one. I love talking about saving money. Absolutely. I'm going to move us on. Someone I see is very beginning, brain health falls, social isolation.
We've got quite a few responses. So folks are actually tuning in, listening, and thank you for your interaction.
Yeah, that's so great. I'm so sad I can't see the chat. Such a huge bummer.
Oh, darn. Do you want
to?
I know.
I want to look at it later.
Okay.
Great. I love that you guys are thinking about this and already thinking about sort of ways that you can shift away from thinking about substance use as the only problem and thinking about, what are the risks associated with risky substance use or illicit drug use? What are the risks associated? And how can we tackle those versus asking people to stop using substances entirely, which is often where the conversation starts. And I think it's so important that we talk about, not stopping using substances entirely because, and this one can be sometimes a little bit controversial, but not all substance use is a substance use disorder. So think for a moment about what defines addiction or what defines a substance use disorder and just sort of generate it in your mind. What's the defining feature of addiction? So addiction is about a loss of functionality, or substance use disorder is about a loss of functionality or a loss of control in relationship to a substance. And lots of people use substances and don't have loss of functionality or loss of control. The way that I often think about this is about suffering. If substance use is causing suffering in a life, then that's a substance use disorder. But lots of people use substances and it doesn't cause suffering. And so it might cause health risks that we might want to talk about, but that's not a substance use disorder. And instead of talking about, substance use or substances, you got to stop all substances. And again, going back to illicit drug use is going to happen. Instead of the conversation being about just stopping substance use, what we want the conversation to be about is that people are going to use substances and we want to address the risks associated and support people in being safer in substance use. And then if someone has a substance use disorder and they're suffering, then we want to tend to that substance use disorder. And that tending can look a variety of different ways. But I really like to parse this out in drug use is going to happen. Some drug use is risky. Some drug use is a use disorder. It's use disordered use. And we're going to have interventions based on risky, how risky it is. Is it use disordered? Or is it simply substance use? And we've got these sort of cultural narratives that substance use is bad. And yet things get really kind of murky in there, because I think most of us would say like, oh, there's some people that can have a couple glasses of wine and it's not a big deal. There's some people that have like a margarita with a meal on a Friday night and it's not a big deal. And then there are people that have an out of control relationship to alcohol. That's a substance use disorder. It's causing suffering, and our interventions are going to be different. But when I take the same idea and then I, transpose it over to methamphetamines or opioids, people often get like, whoa, that's really wild to think about. So if someone can have a margarita on a Friday night and they are, a social drinker and they don't have concerns with it, then we probably don't need to address it. If they're not having any risky behavior associated with it and they don't have a substance use disorder, we maybe don't need to address it. Some of our clients may use methamphetamines sometimes. And it may be that there's some risks associated with it that we want to address, but it's not necessarily a substance use disorder. Some of our clients may use illicit opioids. Some of our clients may use heroin or fentanyl, and there's some risks associated with it. And we want to address those risks, but it doesn't necessarily mean that it's a substance use disorder. My favorite sort of thinker and writer on this is Dr. Carl Hart. He's an amazing sort of addictionologist and theorist, lives in New York City, and he's a very he's a published author. He is professor, I think at NYU, although I'm not remembering in this moment, but he's very successful professor and thinker. And he's been very honest that he uses opioids intermittently the way that some people use alcohol. And so I just want to highlight here that sometimes our clients are using substances. Oh, I see that someone put something in a chat and I really want to know what it says. But I just want to acknowledge that sometimes our clients are using substances and it's not necessarily a substance use disorder. And so again, we want to pivot the conversation to, are there risks associated? Is this a group living facility where someone utilizes alcohol only every couple months? Maybe they don't actually meet criteria for a use disorder, but when they use alcohol, it's pretty disruptive to the rest of the community. So then let's talk about the behavior that disrupts the rest of the community, and we can focus less on the alcohol piece. What was the comment about, what was the quote about addiction that got put in the chat? Will someone read it for me?
Absolutely. It says addiction is a relationship with a substance or behavior that creates an increase in tolerance, a decrease in control, and continued use despite negative consequences. It's a complex web of systemic, biological, and environmental factors. And it is Britt Frank, and it's from Melissa McClave is the one that posted it, and she's using Britt Frank as the person who is being quoted.
Oh, interesting. Okay, great. Yeah, I love that. And it reminds me a lot of the American Society of Addiction Medicine new definition of addiction, which is the one that I tend to use. And I just want to highlight that the American Society of Addiction Medicine and the quote that was just put in the chat, those are both in some ways pretty revolutionary. They both use the term environments. And we'll come back to this when we talk about trauma-informed care, because the evidence that shows early life adversity and promotion of vulnerability to developing a substance use disorder is so big that we've changed how we think about addiction. We no longer think of this as sort of a moral failing. We now conceptualize addiction as really being something that that is about loss of control in relationship to a substance or behavior or process, and often develops out of life experiences, especially adversity. So we'll come back to that a little bit when we talk about trauma-informed care, because it's a really new way of thinking about addiction. And it's a new way of thinking about who develops substance use disorders. And it's very different than how we thought about it even 20 or 30 years ago. All right, let's move on to the next tenet of harm reduction. And that one is that quality of life always trumps total abstinence. And you guys probably noticed that all of these are starting to sort of overlap a little bit. So quality of life is more important than total abstinence. What we're talking about here is, are people suffering, not are they using substances or not. If there's one sort of reframe takeaway from today, it's we want to talk about how to decrease risk and how do we decrease suffering, not stopping substance use. Substance use can increase risk and sometimes cause suffering, but that's not the frame of this conversation. So when I'm working with clients, I'm thinking so much about their quality of life versus are there substances involved or not. And I think I really like have learned this over the years in working with clients. In part, really listening to people's lived experience of using substances. And one of the times when I really started to think about this a lot and sort of think about it differently was working with the first client ever that I worked with at their end of life. So I had a long-term patient, and my specialty is addiction psychiatry. I had a long-term patient. We'd been working on opioid use disorder and PTSD, among other things, for several years. When she was diagnosed with a pretty aggressive form of cancer. And it was an aggressive form of lung cancer associated with many years of smoking cigarettes. And we were talking about it. And as she neared the end of her life, she said to me, she said, you know what, Lydia, I don't regret any one of those cigarettes. None of those cigarettes do I regret, because at the time I needed them. At the time I needed that cigarette to help regulate my emotions. At the time I needed that cigarette to give me something to do with my hands when I was upset or stressed. At the time I needed those cigarettes, and I don't regret any of them. And I remember sitting with that and thinking about how differently I had been trained, which was that like addictive substances were bad, and that it was about the substance being bad. It wasn't about sort of quality of life for people. And many times, especially when people come into services, they are using substances and it actually improves their quality of life. That doesn't mean that always and forever their life is improved because of substances. But again, for example, I have people that use methamphetamines, don't have methamphetamine use disorder, and use methamphetamines to keep themselves safe. And so what we want to talk about is quality of life, not whether there's drugs or not. Because remember, there's probably always going to be drugs. Illicit drug use is going to happen. That's part of it. So is there suffering is really the question here. And then is there risk, and can we decrease the risk? And harm reduction would say that we can almost always decrease the risk, that safer drug use as possible. And that our role as helping providers is to shift the conversation from stop using substances to let's make drug use safer while you're using substances. Another core tenet of harm reduction is to include the voices of people with lived experience. So harm reduction is both sort of a public health intervention that includes much of the above, but it's also a way of thinking about how and whose voices we listen to. So I always highlight that I'm a person with lived experience, and not just an academic, although I certainly have lots and lots of privilege as an academic, but because I've utilized services for substance use disorders before. I've been there. And each time that we want to make choices about, whether it be program design or policy or curriculum development, we always want to include the voices of people with lived experience. And I would even go so far as to say these tenets come from Harm Reduction International, but I would even go so far as to say that we want to include people with living experience when possible. When possible, if let's say we're going to design research around substance use, I would hope that we include the voices of people who are actively using substances. If we are looking at how to decrease overdose rates, let's please include some people that are actively using substances in thinking about how to decrease overdose rates. It has always been sort of at the cutting edge of harm reduction, has always been people who are actively using, have been the people that are sort of most involved and understands what is needed by the community most in that very moment. And again, this is something that historically that feels sort of a little bit radical or even like controversial. Like, well, how can you work with people that are using substances? And it is absolutely possible to work with people using substances. So people with lived experience, people with living experience, those are always included in harm reduction theory and thinking. And then the final sort of tenet of harm reduction is that stigma is central in our understanding and our response to substance use disorders. And when I say it's central, what I mean is that unfortunately, stigma has shaped so much of what we think we know about substance use disorders. And there's so much that potentially we've gotten wrong, and it's based on stigma. And I do like a whole 8-hour class on stigma and substance use disorders. So I feel like I'm not going to do it justice here. And it's going to be sort of a little bit hard to expand on this because I think it's so important and I think it's so nuanced. But I just want to highlight that so much of what we think we know about substance use disorders is more likely based in stigma than it's based in the science. And this, unfortunately, goes back really to the turn of the 19th century, or excuse me, turn of the 20th century. Sometimes I feel so silly. I'm like, I have a doctorate, but I confuse the 19th century and the 20th century. I also don't ever know how to spell privilege. It's something I think about all the time, but I cannot spell privilege. It's totally embarrassing. But unfortunately, the way we think about substances really goes back to the turn of the 20th century and is really grounded in some real, like big, thick racism, right? So the way that we think about substances and the way that we sort of conceptualize how we think about substances, so much of that has been culturally created over the last sort of relatively big chunk of time, and unfortunately is grounded in some stuff that's not evidence-based, that's not based in science, but instead it's grounded in some stuff that we really, really want to be moving away from. So when I'm working with my psychiatric nurse practitioner students, and not so much you all, but I think a lot about, well, what does the evidence say? Because so much of what we think we know about addiction is based on these old stigmatized cultural narratives, and it's not actually grounded in the most evidence-based literature. So definitely think about, okay, what does the evidence say versus what does the stigma say? And harm reduction is sort of a central tenet would say every time you're going to be thinking about addiction, make sure it's not grounded in stigma, make sure it's grounded in evidence and human rights and justice. All right, next slide. This is actually perfect timing. I want to give you guys a very, very short break. I think because of technical difficulties, we're running a little bit late today, but I still want to give you guys just, essentially like a stretch break. I don't want you guys to sit here and stare at screens for 2 solid hours. So it's 11:05 in Colorado, so 10:05 in Oregon. Right? Yeah, 10:05 in Oregon. And so just stand up for a second. We're going to come back at 11:10. Just stand up, stretch, get some water, go to the bathroom, reconnect to your values, and we'll come back together at 11:10. No, 10:10, depending on where you are. 10 after.
Hello. Is there a problem with the videos or something?
No.
Well, I can't start mine because it said it's off by the host.
The video is off by your host.
It says start video. Every time I push it on there, it says you cannot start your video because the host has stopped it.
Are you trying to share your screen? Is that what the button you're
I'm
pushing?
trying to get back online. It doesn't. The host has asked you to start your video. Okay, thank you.
You're welcome. There
There.
you are. You were just
Yeah,
pushing
it
the
wouldn't
right
let me get back on there. It was blocked out. I thought, well, why can't I get back on here? The
Because you were
host had-
trying to join with her, and we like, no, you can't join with her. But that's okay. Your camera button is separate, so you go ahead and we see you now. Can you see it?
Okay.
now?
Yeah, but I wasn't trying to join with her. I was trying to get back over here to this screen. And there is a
All
drop.
set then?
Hold on. I'm trying to get back in this drop. It says you have to change at the bottom where it says my name and direct message. There's a drop. But okay.
Yeah. So do you see it in the messages? There's a little blue box.
Okay. It says everyone. Okay.
Yes, ma'am. Y'all set?
Yes, it's everyone. Yes. Okay.
So we're in break. You go ahead and take a couple minutes, and we'll see you when you get back.
Thank you.
You're very welcome.
Great. So I think we're done with break. Can you guys hear me now?
Yes.
Oh, great. Okay, good. Angela Franklin, will you move the slide forward? Awesome. All right. So hopefully you guys got, you got to stand up for a second, you got a sip of water, you ran to the bathroom, whatever you needed to do. I want to talk a little bit more about harm reduction, and then we're going to pivot to trauma-informed care and older adults. So just really quickly, let's do some quick harm reduction examples. And you guys probably are pretty fluent in these. And it's all the stuff that we traditionally think of as harm reduction. So I've got a needle exchange ban on here. That's kind of classic harm reduction. Narcan is on here, again, classic harm reduction. There's a supervised injection site or a supervised consumption site on here. This is Insight, where you can see the lighted stalls. That's Insight up in Vancouver, BC. And we're going to actually come back to talking about Insight in a second. And it's where people actually go and consume substances. And it's supervised, and there's nursing staff at all times to help prevent overdose. And it's a pretty fabulous model that's very, very evidence-based. The other thing you'll see on here is, see those lighters? It's a little bit of a small picture, but this is one of my favorite more recent harm reduction interventions, which is lighters, because people have a tendency to smoke fentanyl. It's not something that is generally injected, although it certainly can be, but it's lighters. So people are using lighters to light things, and it's got the 1-800-NEVER-USE-ALONE hotline number on it. So it's right there when you're going to use 1-800-NEVER-USE-ALONE. And that's something you can Google if you're interested in it. I give it to essentially all my clients, regardless of what substances they're using. Call this number and someone will stay on the phone with you while you use, to ensure that you don't experience an overdose. You can also message them on their website, and I believe you can text them as well. So it's a pretty fabulous intervention when people are using substances. And just think for a second, what's the meta message for the client when you do something like give them the Never Use Alone hotline? When you give someone a number like the Never Use Alone hotline, what you say is, I'm still going to provide care to you, even if we both know that you're going to use substances. That's not something that people experience very often when they're involved in social services or healthcare services, this kind of non-judgmental acceptance that they might use risky substances. And it's pretty revolutionary for patients. It's a really good feeling. I also sometimes I'll write a prescription for Narcan, or I'll give someone the Never Use Alone hotline number. And what they'll say is, they'll say, "Oh, Lydia, you think I'm going to use again?" And so then I have miscommunicated the meta message, right? Like I've given them this message that I don't think that recovery is possible. And what I always say is, I absolutely think you got this. And I want to be safe, because regardless of what happens in the future, I want you to be safe and I want to see you again. And I think you got this. I think recovery is possible. I've watched hundreds of people recover at this point, probably thousands. I absolutely know in my bones that recovery is possible. And so I'll try to communicate that with patients. But as a general rule, the meta message, when you give people Narcan or when you give them the Never Use Alone hotline, the meta message is, hey, I'm not going to stigmatize you in services, even if we both know or think that you may use substances again. And then I want to highlight here that harm reduction, we're talking today about substances, specifically as it relates to older adults. But harm reduction has permeated our life, really. I mean, we use seatbelts, we used masks. Some of us still use masks regarding COVID-19. My kid and I flew to Colorado. We wore masks on the plane and in the airport. So harm reduction has permeated our lives. The concept, this is something we now think about more. And I actually appreciated during COVID that more people were talking about harm reduction from a sort of global public health lens, which is that, hey, we need human connection. How could we do human connection in a less risky way? Hey, sometimes people are going to use substances. How could people use substances in a less risky way? Versus this kind of all or nothing thinking that can permeate things when we think about risk. it's easy when we think about risk to get pretty all or nothing about things. And so I appreciate and want to highlight that harm reduction has infiltrated how we think about multiple things in our lives. Seatbelts, masks, it's all over the place, right? All right, next slide. With this slide, I want to highlight that I often think that there's sort of this push-pull that can happen between traditional recovery and harm reduction. And I think we want to get away from that. It's not a either or. I really think it's an and both. And I don't ever think that harm reduction has to be a way for people to get into traditional recovery. People should be supported, and their basic needs should be met regardless of where they are in the disease process, regardless of the decisions that they make, etc. People need support and unconditional positive regard and love, and they should be invited into services. And I do think that the evidence is really strong that if we want people to get into recovery and use substances in a much less risky way, that harm reduction is part of how we get them there. So it's common that I hear people say, like, well, that's a harm reduction program and this one's an abstinence-based program. And I struggle with that a little bit, because I have worked at and been the medical director and done all kinds of stuff with quote unquote abstinence-based programs. And I got to tell you guys that people are still using substances. It's just, we're often not talking about it as honestly. And I'm talking about outpatient here specifically. I think very differently when I think about withdrawal management settings and supportive living settings. But in an outpatient setting, it's oftentimes like, oh, this is an abstinence-based program, but people are still using substances. We're just not talking about it. And so in my mind, these two things go together, and they actually go together really beautifully, because most people don't just stop using substances overnight. Most people, especially with opioid use disorder, we know that it takes roughly 7 on average attempts at treatment services before it sort of sticks long term. And so people come and go from use and active use, and they're not actively using. And what we want to do is get nimble and meet people where they are at. And harm reduction often is an avenue for engagement. So what I'm highlighting here, and just a second ago, I showed a photo that included Insight, which is a supervised consumption site up in Canada. And the data for Insight is fabulous. It shows that there's like decreased needle waste in the areas around, there's increased overdose rates, decreased communicable diseases. There's all these benefits to it. And on top of those sort of community-wide benefits to it, also people were much less likely to engage in recovery services that were connected to that consumption site. So if people used the consumption site, then oftentimes those same people then would go to withdrawal management that was run by the same organization and co-located in the same building, which I think is such a fabulous model. We often say, well, that one's harm reduction, this one's abstinence-based. And what I think is that it's really and in both. Like, we meet people where they are, we get their needs met, and that's a way of engaging people. And this really highlights, I think, the need to have non-stigmatizing services. People that use the supervised consumption site had a really easy time going into withdrawal management in the same organization because they didn't feel stigmatized. They felt like they were being supported regardless of the choices that they made. So again, it just highlights sort of how big stigma is. And if we remove that stigma and meet people where they are at each pivotal moment, then we actually get more engagement over time, and people are always safer when they're engaged in our services. The worst thing that we can do when people are actively using, and again, this is location and setting dependent. I don't say this as an absolute, but as a general rule, when we discharge people, we are going to make them less safe. So we really, really work to not discharge people when we're working from a harm reduction perspective. All right, next slide. Let's talk just for a second about trauma-informed care. And this is where I'm most upset that I can't see the chat, because I think you guys can probably tell me just as well as I can tell you how trauma-informed care and harm reduction overlap. But maybe you guys could unmute for a second, or maybe you could put it in the chat and someone can read it out loud. where are the connections between trauma-informed care and harm reduction? How do those two things line up? Angela says compassion-based, and that one was short enough I could read it even on my tiny iPhone. Yeah, they're both very grounded in unconditional positive regard, and they're really, really focused on compassion. Transparency. Yeah, absolutely. Ronnie said transparency. And again, I can read it on my iPhone because it's short. One of the 6 principles of trauma-informed care is transparency. And when people are using substances and able to talk to you about that, and then there's transparency that your relationship with them and your tending to them will continue, that's trauma-informed and harm reduction at work. Absolutely. Transparency is core to both. What else do you guys see as connecting these two paradigms of care?
So we have autonomy, we have
Yeah.
empowerment,
Yes.
and we have folks often use around trauma.
Oh God, you guys are so good. See, you don't need me to talk about this stuff. You know all this stuff. Okay, so autonomy and empowerment. So empowerment is one of the 6 principles of trauma-informed care, and harm reduction is all about empowerment, right? Harm reduction is all about saying, hey, you're still going to do this thing. Hey, how do we make it less risky? You get to choose for you what you do. Absolutely. And autonomy. I don't have enough time to really break this down, but really when I think about trauma, I think of trauma being essentially an experience of a loss of control. And so giving people control over their choices, whether they be risky or not risky, is one of the most trauma-informed things that we can do. Hey, you're still going to use, and I'm still going to tend to you and love you and care for you. That's incredibly trauma-informed and harm reductive. And then someone said, people often use around their trauma. Yeah, we have this paradigm shift over the last 10 years or so, really recognizing the impact of especially childhood, but also adult adverse and traumatic experiences. And that's part of how and why people use substances. So much substance use is about managing really, really hard emotions, memories, etc. And so we understand substance use from a trauma-informed paradigm. We understand it to be something that doesn't always decrease someone's quality of life, which again, that's one of the tenets of harm reduction, right? Hey, sometimes people use and it actually helps. Sometimes people use, and although it's risky, it felt beneficial for them in that moment. And I can really relate to that as someone that used alcohol heavily for many, many years. I can really tell you that like that alcohol probably saved my life. So quality of life trumps whether it's risky or not. And that's both trauma-informed care and harm reductive. Absolutely. Yep, you guys got it. So these two things go very, very well together. And especially in the state of Oregon, behavioral health services have a mandate to be trauma-informed. And harm reduction is incredibly evidence-based. So there are two paradigms that we want to pull in for everything we do. And it's beneficial because they overlap. They really have a lot of sort of core overlapping values-based space together, which is great. All right, next slide. All right, so same, I have a bunch of ways that I want to talk about older adult considerations and harm reduction. But I think many people on this call probably specialize in older adults and geriatric concerns far more than I do. So just like trauma-informed care, I really want to hear from you guys where you think there's special considerations for older adults and or geriatric populations from a harm reduction perspective. And what I had planned to do here is I had planned to type it into the screen while I shared my slide. I can't do that on my iPhone. So you guys are going to have to just kind of hold it in your head and I'll reflect it back. What do you guys think? Ooh, need to overlap for dementia. That's one that I hadn't thought of. Yeah. Prescriptions overlapping. The stigma in the older, ooh, I just can't read it all, but something about stigma in older generations.
The stigma in the older generation is the most strong and shame
Mm.
based.
Strong and shame-based. Yeah, I love it. I mean, I don't love it. I don't love that that's true, but I love the thinking behind the comment.
Navigating assisted living facilities while folks are in active use.
Really, really great point, Calypso, and something that I've oddly worked on a lot in the last year or so. Yeah, when people are actively using and it's assisted living facilities where there's a community involvement, things can be really challenging. Absolutely. Any other ones that you guys want to throw out?
Mobility issues can affect opportunities to escape triggers for use.
Ooh, yeah.
And
Yeah,
that
mobility
could also
issues.
be for not just physical, but that could be for location, because we often deal with people that live in rural communities. So that would be, and then health issues needs may be different, and then co-occurring physical health conditions that impact abilities, functions, and energy.
Yeah, absolutely. I love the way that you guys are thinking about this. Absolutely accurate.
I was gonna jump in. I also feel like housing is a
Yes.
huge aspect, because when someone is actively in their use and they have co-occurring physical impacts, the housing options become almost non-existent when it
Yes.
comes to residential programs, because they can't attend to their physical needs.
Yep.
You're caught between
Absolutely.
those two worlds.
Yeah.
Physical health,
Definitely.
behavioral health.
We'll say the last part again.
You're caught between, we can't take care of you because you have too much substance use. We can't take care of you because you have too much physical ailments. So
Yeah, absolutely.
Or
Yeah.
we can add that you have mental health issues and now we can't serve you, because that's what I am running into. We also have 3 that were listed for end of life situation, pain management struggles, and lastly, support networks may be smaller or non-existent. And then mine recently was you have older adults who are just aging past where everyone else is, and there is a complete loneliness, and there is a lack of, and so they are filling space or trying to have time go quicker so that it is not dragging on. Then we have recognizing the person as a whole human creates acceptance of using while finding moments of shared love experience. Housing first, PSH programs that require folks to be able to do ADLs. And then we have set in traditional paradigms, views can be barriers to harm reduction. I would like to also add religion often has an issue in guilt. A lot of our older adults are religious based.
Yeah, that's a really good one. I think religion is a great one that I really hadn't considered. And I sort of heard kind of a golden thread in a couple of those a little bit ago that really has to do with isolation.
Yes.
And we'll come back to this in a second. Older adults tend to be more isolated. And so some of the traditional harm reduction interventions just aren't going to work for older adults. So yeah, I heard a couple of things in there that sort of all harkened back to this idea that older adults, the evidence says, are much more isolated.
And then one just came up that says set in traditional paradigms, views can be barriers to harm reduction. Absolutely.
Yep,
Great.
set in traditional paradigms and views. Yeah, absolutely. Because we're in the midst of this wild paradigm change around substance use right now. And I'm only really tracking it because it's my specialty. But when I think about folks being isolated, I really think, yeah, we're stuck in these old views. People are more likely with isolation, are more likely to be stuck in old views around substance use. Absolutely. Yeah, you guys, those were such good ones. Again, I love the way that you're thinking here. And I think we could spend like a full 8 hours teasing apart, like, what about this issue and how it relates to harm reduction? What about this issue and how it relates to harm reduction? I want to highlight a couple that I think are particularly salient based on the evidence. And when I say the evidence, and we can go to the next slide, Angela, when I say evidence, this is not my specialty area. So when Angela asked me to come and talk about older adults, I was like, that's not really my specialty. I do work with a lot of patients that are functionally geriatric. So folks in their 50s essentially, but because of substance use and trauma and a lot of poverty, they're sort of functionally geriatric. They're taking a geriatric number of medications, or they're very isolated. They're functionally geriatric. So I have a lot of experience with it, but it's not something that I think about on a regular basis. It's certainly not my specialty. And so what I did is I went and I tried to pull any literature I could find around older adults and substance use, older adults and harm reduction, older adults and sort of shame and stigma and isolation. And so I pulled out sort of these 4 themes that kept coming up in the literature over and over again. And I wanted to just sort of highlight them. Although I think you guys already sort of got these plus some, but let's just talk through what comes up a lot in the literature. So number one thing is, when we think about harm reduction considerations around substance use, a lot of that is about public health interventions. A lot of harm reduction for substance use is about these public health interventions where people that use substances are going to the needle exchange, and then at the needle exchange, they might be targeted for things like Narcan training. And when I say targeted, I mean in a positive way. They might be sort of invited in for like Narcan training or fentanyl education, or like large public health campaigns. And public health just does a bad job of really tending to the needs of older adults. So interestingly, what the public health literature says most about older adults and harm reduction is that public health misses older adults in its interventions. When it designs billboards, for example, about overdose prevention, it doesn't do so in a way that's designed to also tend to the needs of older adults. So probably number one thing, at least in the literature, is we just do a bad job of doing harm reduction for people over a certain age. And part of that is because they're more likely to be isolated from communities of people using substances. So older adults, as they age and become more isolated as a general rule, are also more isolated from communities of people that are also using substances, and the public health interventions are not going to reach them as much. And that's part of why I was so excited to do this. Or maybe I should say I got more and more excited as time went on, thinking about how exciting it is that we're able to have a conversation where there's an intersection of harm reduction, which is a not always super utilized public health intervention, and then talking about that specifically for older adults. How cool is that we even are carving out time thinking about how much we value the older members of our communities and how we can tend to them best. It's pretty exciting. And then that trickles down, that sort of, will someone read Roberts? The isolation then creates, I want to see the rest of it or hear the rest of it.
And the isolation then creates and or intensifies mental health concerns.
Oh yeah, absolutely. Absolutely. So then folks are isolated, mental health gets worse. And, that's the, I would say second to stigma, that the reason people often have a hard time engaging in recovery services is mental health concerns. And we don't always do the best job at tending to people with co-occurring disorders. Evidence on that one's really clear. We struggle with tending to people that have both, and yet everyone's got both for the most part. Everyone's got both, but we do a real bad job of it. Yeah. All right. So then that idea of public health interventions not targeting older adults, that actually trickles down into a clinical setting. And what we see is that there's a little bit of sort of bias and judgment on the part of providers, where providers are less likely to consider risky substance use in older adults. So risky use is missed. So let's say someone comes in, for example, to a primary care provider. The primary care provider may not ask them any questions about how much alcohol they're drinking or if they're using IV drugs, because we just sometimes think older adults aren't doing that. So clinicians sort of can enact the same thing that public health does and just miss it. And so much of this has to do with representation. We've got sort of these stories about who substance users are, who addicts are, quote unquote. And so if you're a clinician that doesn't specialize and think about addiction on a regular basis, you might just not screen someone for a substance use disorder because they're over 60 or they're over 70, and you think that it's not as much of a concern because we don't think of people with substance use disorders being in that age range. And so it gets missed. Those like common things that we do to screen for risky substance use, we then don't do those for people. So clinically, it is often missed, and we miss an opportunity to talk about risky substance use with folks that are older. The other thing that comes up in the literature, and this one I found really interesting, is that older adults conceptualize themselves as less at risk. And I think this goes back to representation again. We have these cultural stories about who people are that struggle with addiction and what they look like and what their lives look like. And so older adults may see themselves represented less in sort of stories and cultural narratives about who people are that are using substances in a risky way, or who people are that have substance use disorders. And so older adults themselves are more likely to engage in risky behavior and not consider it to be very risky. And where this really, really comes up, interestingly, is around sexual behavior in older adults. Older adults tend to engage in much riskier riskier sexual behavior, in part because public health interventions haven't targeted them, and then in part because they conceptualize themselves at less risk because of sort of what I would call the representation concern. And then a really, really big one that you guys did a great job of articulating over and over again was this idea that as people age, there's more polypharmacy. And there's more medical comorbidities. So things that make substances riskier, including polypharmacy and medical comorbidities, increase as we age. So as we age, and when I say polypharmacy, it's just a fancy way of saying there's multiple prescribed medications. So a good example of this would be someone has maybe a chronic pain diagnosis, and also depression and some liver health concerns. And they may take several medications that slow their central nervous system just ever so slightly. So maybe they take gabapentin as well as clonidine and amitriptyline. Common medications we see as people age and in a primary care setting. And then the person who's taking 3 medications that slow the central nervous system just ever so slightly, then that person drinks 7 drinks on a Friday night. And all of a sudden, those 3 medications actually become very risky. Whereas if someone was younger and on fewer medications, or let me just say this differently, if someone was on fewer medications, it's fine to take that combination of medications. We do it all the time. And then same goes for medical comorbidities. So if someone's got, let's say a progressive liver disease as they age, then those polypharmacy concerns are going to be expanded upon, they're going to become bigger, and medication interactions are going to be more intense. And then if you add other illicit substances, things just become much riskier. So the takeaway on this is that behaviors that maybe aren't as risky become much riskier as we age, and especially because there's sometimes this polypharmacy as people age that we don't see in younger adults. So those are the 4 things that that I pulled out. And here's what I'd like to do. I'm hoping that I'll get to see a transcript of the chat. And so what I'm thinking is I can send out the slides from this talk, or the organizers will send out the slides from the talk. And in that, we can include just some bullet points of other things that you guys highlighted, because I can sit here and I can tell you guys all about sort of harm reduction as a conceptual paradigm. And it's much harder to really enact it and really think from a harm reduction perspective when we're working with clients. And then it's that much harder to enact it with older adults, because it's not what is so commonly reflected back to us. Plus, older adults have these things that these additional challenges, such as isolation and polypharmacy and public health interventions not targeting older adults. So then there's just I think a need here for me to highlight and sort of consolidate some of the thinking that you guys had around, Angela said something about insurance coverage is limited. I would love to know the rest of that. But yes, I want to put together sort of some bullet points around older adult considerations for harm reduction, because I know that's why you guys are all here. And so we'll try to reflect it back to you in the best way possible after I sort of zoom through the chat. Is there anything else that you guys want to add? Angela just added insurance. Will you finish? Will someone say that whole statement around insurance?
I just put insurance coverage is limited as well. So a lot of the organizations that rely upon funding for being able to bill their, CCOs or just engaging in services with someone who's an older adult, it doesn't happen that much, especially when people have Medicare. And
yes.
So there's things that even within, the mental health organization that I work for, we cannot provide case management to people with Medicare unless they are considered indigent.
Right.
And then we can do a waiver. Yeah. So it's it's tricky. Yeah.
Yeah, thank you. It's funny because I actually hadn't thought about that. And then as soon as I saw this little thing pop up that said insurance, I thought, oh my gosh, yeah. When folks have Medicare and don't also have Medicaid, the clinical tools I have to serve them, especially in the context of risky substance use, it just plummets. So for example, we use a lot of a long-acting form of buprenorphine or Suboxone, a long-acting injectable, and Medicare doesn't pay for it. And it's one of the best tools we have against opioid overdose right now. So yep, absolutely. When insurance is restricted to Medicare, which is so true for so many of our older adults, resources just get so much more limited, and we have to get so much more creative about how we manage risky substance use. Yeah, definitely. Are there any others that you guys have thought of that you want to sort of, that you want me to call out later and include in a list of considerations for you?
I think one of the things that came up to me is educating support staff at assisted living communities with just what harm reduction trauma-informed care is, because those are the folks that actually are usually the only advocates for older adults in those settings.
Yeah, I think Calypso mentioned this a little bit earlier, and I think it's so true. I have been amazed and also excited because I've been invited to a lot of assisted living facilities in the last year or so to talk about, kind of addiction 101, because we're seeing more and more addiction in assisted living facilities, or maybe we're not seeing more, but we're thinking about it differently. And there's a request to, we don't want to just discharge this person. We don't want this person to be on the streets, and we don't quite know how to manage some of this risky behavior that's impacting the community. Yeah, it gets really complicated. And yes, education for assisted living staff, because this is really hard stuff, really, really complicated, hard stuff. It can be really challenging. And often assisted living staff have some of the least education around substance use disorders And unfortunately, when people have limited education around substance use disorders, sometimes, and it's not always the case, but sometimes what takes the place of it is what we learned from common cultural narratives. And those common cultural narratives are often wrong and are rooted so much in stigma. And so I'll just highlight this really quick, and then I want to pivot to questions. But I think this is kind of a useful place to end. Is just thinking about all these things that we learned about addiction. And I want you guys to tell me where you learned about addiction, and think way back, like go back to like some of the earliest memories you have of learning about addiction. Where'd you guys learn? And just put it in like 1 or 2 words so that I can catch it in the chat. TV shows, just say no. Yeah, Dare. All right, someone said family, high school. Ooh, public health class. Okay, cool. Good. Family. This is your brain on drugs, so Dare. All right, so we got a lot of family. Ooh, we got church. A lot of family, church, Catholic school, health psychology training. Okay. Own experience, lived experience. Yep. Yeah. Dare and abnormal psychology. Great. You guys actually have very this group of people, I think, has more like interesting and nuanced ways of learning about SUDS. It is so common that people say, oh, I learned from TV. And so TV and Dare, those usually are the 2 places that people learned the most. So even if it was like school, maybe it was like Dare influenced. And I want you guys just to think for a second. Just think for a second, if you can think of one TV persona, and I mean fictional, that is good and has a substance use disorder. And when I say good, I mean, that's kind of a weird, like moralistic word, but what I mean is not selfish and has the ability to recover. So not selfish and has the ability to recover. Do you see that reflected back in TV and movies? Think if you can think about one character. Someone said no, just a flat out nope.
What was the question?
So do you see any persons that are responsible drug users? So I am a Black woman. In my community, there is not one person that would be represented on TV or in any other cadence that would be positive drug use. Not one.
Yep. Yeah.
That represents me. Now, that's why I said no. Now, if you take on TV, Sherlock Holmes would be my first guess. But outside of a person that looks like me or my community, I don't know anything that is on TV.
Yeah, I love that you said that, because usually people can think of a couple, although they are a little bit selfish. Usually people can think of a couple, but they're almost all white men. And this feels really salient to me because I remember searching so hard, like, can someone be reflected back, that someone that's selfless, not selfish, and able to recover? Can I please see that in a fictional character? And the first place I saw it was West Wing, and it was a whole bunch of white guys that were nothing like me, right? So usually I spend much longer on that exercise, but people come up with a couple folks, but it's almost always white men. And there's a couple that are newer in just the last couple years that are great representation, which I think again is like a reflection that we are entering into a new way of thinking about this, a new way of seeing this. If I really, really like This Is Us, I think it's got some of the best portrayal of substance use disorders, but it's a new show. We didn't grow up with that. That didn't help to construct our thinking as we grew up. So yeah, just thinking about those assisted living staff and sort of the stories they have about substance use disorders and who people are with substance use disorders, that stuff's really big. Those cultural narratives impact us much more than I think all of us would like them to, because we want to be evidence-based and we want to be compassionate. And yet a lot of that stuff has sort of seeped into our brain. And then that's going to impact older adults even more so, for all of the reasons that we've discussed today. And I will leave us on that note. Hopefully that made a semblance of sense, what we just did. And we have about 10 more minutes for questions. And I think I saw a question earlier in the chat that I couldn't, someone said, do you see a difference? And I couldn't see the whole question.
I'm skimming back to see if I can find it.
Ooh,
So
thanks.
it says, do you see a difference based on the activities available in the facilities and human interaction versus those that don't necessarily have those options?
Oh, so a question about assisted living facilities. Is there a difference in the amount of risky substance use if there's more activities? I love that question. I honestly have no idea. It's not something I've tracked, or it's not something I've had the intimacy with those assisted living facilities to understand or know. Yeah, I love that question though. I love the thinking behind it. It's fabulous. What other questions do you guys have?
I'll jump in. I'll say thank you. My grandmother, I'll do some vulnerable sharing. My maternal grandmother was a drug user by choice. She used on the weekends. I had a classmate, and when I was in graduate school, a mother who chose to use every 3 months. She would set her daughter up. She would set her up with, a safe person. She had a hotel. She saved her money, and she went for that Friday through Sunday, did what she wanted to do, and she came home and waited for 3 months. So it was really, really helpful to say I've been out of graduate school over a decade, right? So this was 10 years ago, right, when this was not talked about. And the fear behind her losing her daughter, the fear behind her losing her job, the fear behind her losing her career were so heightened, right?
Yeah.
And she went through all this care and preparation to make sure that when she would be tested at work. So I appreciate the conversation of saying that normal people do this, because I have had that experience as well in my work. And my first experience was my own grandmother, who chose to use drugs and alcohol on the weekends because she said that she was an adult and this was her way to relax and hang out. And she did it well, was her word, right? She did it within the confines of her home. She didn't drive. She didn't hurt anyone. And as far as she was concerned, that was her right as an adult. And so I really, really appreciate how you have presented this information, because it often, for me as a social worker, is about harm reduction. And for years, I grew up in the Bay Area where alcohol and drugs are huge for a lot of reasons, but not having a nuanced conversation and just telling someone to stop. Thank you for saying it's not always the answer, and absolutely isn't always possible. So I really appreciate the opportunity to see that from many different views and cadences.
Good. I'm so glad. That's such a lovely story. We have this vision of like all drug use is bad. And you just gave an amazing story of drug use not being bad, right? She didn't have a substance use disorder. There was no suffering. It was very much an active choice, and it was done without a lot of risk. The conversation was about risk, not is it good or bad.
Drugs now are no longer illegal, right? And so my grandma was very big about that. And she, just like you said, if I were something else, would this be a problem? And that's why she would say, if I was a man, would you be talking to me about this? And let's also talk about, in my mom's time, when she worked, my mom was a drug user, but when she worked, cocaine was in the office. My mom worked in San Francisco on the 34th floor. Cocaine was offered to everyone that came in a drink, and a little glass thing with a little spoon. And that was not a big deal. It was set out, and it was her job to sit it out. And then when my mother left that job and was addicted, she went to other drugs. But my mom became addicted at work. She was not a drug addict. My mom was a high-end secretary, an administrative assistant that got addicted at work because drugs were available at work. And so was alcohol. It was her job to pass it out to high-end men when they came in.
Interesting. That's fascinating.
So trust me, life has changed, because what used to be, right, this thing, when you go into high-end offices, drugs were set on the coffee table for you to use as you wanted in San Francisco, California.
Yeah. Yep. Gosh, that's so fascinating. Our cultural stories about drugs are so interesting. So interesting. Yeah. I think we have time for one more question.
So the question is, just out of curiosity, do physicians put older adults who are in assisted living facilities on pain contracts?
Oh, this is a really good question. And there's actually, I don't feel like I'm well equipped to answer because there's new CDC guidelines on managing chronic pain, and they've shifted their recommendations pretty radically. And I actually don't know what their new recommendations are. I know that they shifted, they no longer require routine urine drug screens, I believe. And I don't know what it says about contracts. And I can speak, I can speak to sort of what I see as common practice in Portland, but I don't know what's happening across the US. In Portland, it's really, really common that people that continue to take opioids for chronic pain are on a pain contract. It's really, really common. And of course, part of the pain contract is I'll not use any other substances. And I appreciate that. I appreciate why that's constructed that way. And also, it means that we don't get to have a conversation about risk, right? We just say, don't do this. It means that we don't get patients coming and being honest with us about the substances that they are using, which offers us a way to have a clinical conversation about being safer. And remember, first tenet of harm reduction is people going to use. People are going to use substances. So part of our role is to talk about how to do so in a less risky way and keep people engaged. So I think the pain contract undoes that a little bit. And I do see it as still pretty common practice. And I think there's a chance that the CADC may be discouraging it. I know Pierre is on this call. Pierre, do you know what that new CDC guideline says about managing chronic pain?
You know what? I'm actually not sure. Well, the new CDC guidelines came out and said, it's okay to provide people pain medications and to be more understanding of the situation that's sort of going on. I don't know what they say about the contract. I was looking up. I know I personally don't believe in contracts for any reason because I feel like we're adults in the room and I can talk as an adult with them. But the people's pain needs to be managed, and it's basically being patient-centered and treating their pain authentically and having that conversation about the risk if they are doing things like marijuana, because I wouldn't want someone to smoke a joint on the weekend and then like on Monday you pull all their pain meds because of that. So,
right.
But I don't know about the contract though. I just don't believe in them, and I think the data is very mixed if they actually really do anything. But if you do it, I'm going to shout out to you, Lydia, because you do have a contract that's very trauma informed and it's written as a perspective of what you're doing as a provider and guaranteeing to the patient versus what the patient must do. And I do appreciate if you're going to do one, do Lydia's recommendation. So,
the trauma informed.
Yes.
It's funny because I try to call it a trauma informed agreement, because in healthcare or in psychiatry, we know that contracts don't work. When we tell patients, like, don't do this thing here, sign here, don't do this thing, and then I'll give you part of what you want, they don't work. They just do not work. And so this should be, from a trauma-informed perspective, it should be very, very collaborative, and it should be an agreement between the patient and the provider.
Nice.
So I like
That's
what you're saying.
The word that we could put down, the overlapping collaborative.
Collaborative. Yeah.
Well, Lydia, we are just a minute over our time, and I want to
so sorry.
let folks give them our closing. And Lydia, this was really great. I think that you opened up a lot of people to think about a lot of things in different ways. And I really appreciate it. And we'll be sharing this and hopefully maybe doing some more intensive trainings with you if you're open to it.
Totally.
Okay, so who is our closing person? There we go.
Thank you, Lydia, for an excellent training today. And thank you all for attending today's presentation. Portland State University evaluates the Oregon Older Adult Behavioral Health Initiative. You will receive an email from PSU, so please complete that survey to receive your certificate of attendance. You will also be receiving another email with an evaluation for the National Association of Social Workers. So please complete that survey today or when you receive it to receive your continuing education credits. And our next training will be on September 7th with our own Angela Franklin presenting on suicide prevention in older adults, the gatekeepers training. So thank you all for attending.
Thank you.